Assalamu alaikum wa rahmatullahi wa barakatuh. Today, our lecture about 2022 American Society of Anesthesiology Practical Guideline for Management of Difficult Airway. I will talk in English today because I think our lecture is very important for any doctor dealing with airway. So let's start. American Society of Anesthesiology developed difficult airway algorithm and guideline. First was 1993, then update these guidelines 2003, another update done 2013, and last update was in October 2021. So is there any guideline for airway management? What other guidelines are there? Yes, there is a lot of guidelines. The DAS, which is the Difficult Airway Society guideline, first was 2004, 2009, 2011, 2012, and last was 2015, which Difficult Airway Society, myself, I like it. It's very simple and easy. Also, there is an Italian guideline and Canadian airway management guidelines. Why all these guidelines? Did you see a lot and guideline and a lot of update? Why all of these? Because difficult airway is the most important cause of anesthesia-related morbidity and mortality. In my opinion, the most important responsibility of the anesthesiologist is maintaining patient airway. Almost 30% of this in general anesthesia due to inadequate airway management. The single most important factor leading to a failed airway is failure to predict the difficult airway. If you try to anesthetize your patient and go for surgery, for operation, and you didn't predict that your patient is having a difficult airway, so you are in a catastrophe. Most catastrophes are due to either unexpected difficulty or poor planning in patient with known difficulty. The actual magnitude of difficult airway in anesthesia estimated around 1% to 3%. However, actual difficulty during tracheal intubation occur in 1.5% to 8% of patients. American Society of Anesthesiology 2022 defined difficult airway as the clinical situation in which anticipated or unanticipated difficulty or failure is expected by physician trained in anesthesia care. Difficult airway is maybe having six or by ESA having six dimensions. It includes, but not limited to, one or more of the following. It's either difficult face mask ventilation, difficult laryngoscopy, difficult ventilation using a supraglottic airway, difficult tracheal intubation, difficult tracheal extubation, or difficult invasive airway. ESA define difficult face mask ventilation as it is not possible to provide adequate ventilation, known by that your patient adequate ventilation by having carbon dioxide in the exhaled air gas detected by end-tidal CO2 or capnogram. They define as it's not possible to provide adequate ventilation because one of or more of the following: either inadequate mask seal, excessive gas leak, excessive restraint to the ingress of gas, or excessive restraint to egress of gas. Before declaring that I am having a difficult face mask ventilation, I should know, I should give my patient the optimal chance, and I should do my best effort to give my patient the optimal face mask ventilation. How to do so? How to maintain optimal bag mask ventilation or face mask ventilation? I have 3 criteria to be fulfilled. First, proper positioning of my patient. Second is to keep airway open or patent. Third, tight seal of the mask. How to do all of this? First, positioning of the patient. Patient should lie supine at least 30-degree head-up position to guard against regurgitation or regurg when lying supine. I should put my patient in a sniffing position, which is head extension and neck flexion. I can do neck flexion by adding pillows behind the patient head. Extension, when I'm doing the sniffing position, there is extension of atlanto-occipital joint and flexion of cervical spines. My aim in a sniffing position is to maintain the external laryngeal, external auditory meatus horizontally aligned with the sternal notch. And we mentioned these in pediatric airway management, in videos of pediatric lecture of pediatric airway management in details. In obese patient, the situation is very difficult. If your patient lies supine, he have rapidly desaturated. So you have to put your patient in a RAM position in obese patient. Putting normal person in a sniffing position, you have to put something, a pillow under the neck of your patient. But in obese patient, you have to put pillows and beds in below the patient head, neck, shoulder, and chest in order to get the external auditory meatus at the level of, at the same horizontally aligned with sternal notch. Okay, as you can see in the lower picture. In cervical injury or head trauma, don't do sniffing position. How to keep your airway patent? Keeping airway patent by either head tilt, chin lift, jaw thrust, or airway adjunct. To do head tilted chin lift, one hand should press down on the forehead, and the other index, the index and the middle finger of the other hand pushing the mandible upward, as in the picture. Head tilted chin lift shouldn't be done if there is unstable cervical injury or cervical spines. Don't do head tilted chin lift in head trauma. You can do jaw thrust. How to do jaw thrust? With doing jaw thrust, you put both heels of both hands on parieto-occipital region and the other fingers in the angle of the mouth, angle of the mandible, pushing the angle of the mandible upward anteriorly and open the mouth with the thumb finger, as in the picture. You can use, to keep your airway patent, I can use oropharyngeal airway, nasopharyngeal airway, or even suction device to suction the airway. As we can see in picture A and B, in neutral head position, there is two curves, the tongue and epiglottis lying down, obstructing the airway. But when we do sniffing position, the tongue and epiglottis displaced upward, leaving the airway patent. Third item to be fulfilled to give optimal bag mask ventilation is bag valve mask hand sealing technique. How to do this? American Society of Anesthesiology recommending double hand technique or two hand technique for mask sealing in patient with predicted difficult airway. Don't use one hand technique, use two hand technique. First, in picture A, anterior and lateral view, we can see the double C and E technique. How to do double C and E technique? Both thumb and index of both hands, making C shape, and lies both on both sides of the face mask. The third, fourth, fifth finger on the mandible, pushing the mandible upward and anterior. Okay, this is the double C and E technique. There is a modified two-handed technique to support. First, before I see how to make a modified two-hand technique, in double hand technique, you need an assistant to make a positive pressure ventilation or bag ventilation, okay? Because you put your hand on the mask. So you need an assistant to give positive pressure ventilation. Another way to mask sealing is modified two-handed technique or V and E technique. You can use the thumb and senior eminence both hand on both sides of the mask, and the other finger in the angle of the mouth, try to elevate the mouth anteriorly and upward. Okay, this is the optimal sealing mask technique. As the American Society of Anesthesiology define difficult laryngoscopy as it is not possible to visualize any portion of the vocal cord after multiple attempts of laryngoscopy. They also define difficult or failed tracheal intubation as tracheal intubation requires multiple attempts or tracheal intubation failed after multiple attempts. They define that direct laryngoscopy or tracheal intubation done by provides that this maneuver done by experienced provider. Any airway management taking more than 3 attempts or any airway management taking more than 10 minutes by experienced personnel or anesthesiologist is considered as difficult tracheal intubation or difficult laryngoscopy. No wonder that they said that they have successful rate 90%, because if we met these criteria, our patient would be dead by now. That's it. Also, ESA defined difficult or failed tracheal extubation as loss of airway patency and adequate ventilation after removal of tracheal tube or supraglottic airway device for patient with a known or suspected difficult airway, patient at risk extubation. If you're facing one of these scenarios, either difficult direct laryngoscopy or difficult or failed tracheal intubation, don't panic. Our aim is not to intubate the patient. Our aim is to ventilate the patient or to oxygenate the patient. Keep calm, maintain mask ventilation, face mask ventilation, provides that face mask ventilation is adequate and you can adequately ventilate your patient, and think of alternative. Don't keep your thinking on how to intubate. You have to put the endotracheal tube. No, you shouldn't. You don't obligate to put the endotracheal tube as long as it's failed or difficult tracheal intubation or difficult laryngoscopy. Think of alternative. Always have plan A, B, C. Always have a plan. If you predict difficult airway, prepare well. Don't rush. Have a plan and call for help. Okay? Think how to oxygenate and ventilate your patient. Don't think how to intubate your patient. Okay? As we mentioned in bag valve mask ventilation, we have also to declare difficult or can't intubate. To declare can't intubate, I have to give my patient the best attempt at conventional direct laryngoscopy. How to give the patient the best attempt for laryngoscopy? Best attempt for laryngoscopy composed of 6 components. First, performed by a reasonable, experienced practitioner. Second, no significant muscle tone. Your patient should be relaxed. You should use the optimal sniffing position as we mentioned before, and use optimal external laryngeal manipulation. It is either PARP, backward, upward, rightward pressure on larynx, or optimal external laryngeal manipulation. This can be done by manipulating thyroid cartilage. You have to use optimal length of the blade and optimal type of blade of laryngoscopy. We will talk about all this in when we next lecture, when we talk about predicting airway and preparation for difficult airway. As I defined, difficult supraglottic airway ventilation is that it is not possible to provide adequate ventilation confirmed by end-tidal CO2 in expired gas because one or more of the following problem. Either difficult supraglottic airway placement, or its placement require multiple attempts, inadequate supraglottic airway seal, excessive resistance to the ingress of or egress of gas, or excessive gas leak. And he also defined that to declare difficult supraglottic airway ventilation, you need to remove the device and think for alternative to ventilate your patient. I kept telling, provide adequate ventilation, provide adequate ventilation. How could I know that I'm giving my patient adequate ventilation? Or what is the indicator of inadequate ventilation? American Society of Anesthesiologists defined difficult or inadequate ventilation as if there is absence or inadequate exhaled carbon dioxide, absence or inadequate chest movement, absence or inadequate breathing sound, auscultatory sign of severe obstruction, presence of gastric air entry or dilatation, the presence of cyanosis, you will find your patient cyanotic, decreasing or inadequate oxygen saturation, you can't maintain oxygen saturation more than 92, absence or an inadequate exhaled gas flow as measured by spirometry, anatomic lung abnormalities as detected by lung ultrasound, hemodynamic changes associated with hypoxemia and hypercarbia as hypertension, tachycardia, bradycardia, arrhythmias, and additional clinical symptom as a change in mental status and somnolence. God save us from facing inadequate ventilation. Because if you fulfill these criteria in your patient and you can't intubate your patient, you are in an emergency situation. You have to rapidly call for help and start surgical airway. Okay. Adverse outcome with difficult airway. Difficult airway is a catastrophe, and manipulating larynx and 3-attempt direct laryngoscopy, this is a very traumatizing. It may lead to either airway trauma, damage of teeth, or cardiopulmonary arrest, God save us, or hypoxic or ischemic brain injury. It may lead to this. In order, now we will know how to predict difficult airway. In order to know how to predict difficult airway, I have to know first airway anatomy and physiology, and applied anatomy related to my career or related to my work. I have to know airway assessment and evaluation, how to evaluate the airway, how to know that my patient that I will anesthetize him is difficult airway in order to prepare and to make a plan. I have to know also practical guideline for management of difficult airway. I may having difficult airway scenario or can't intubate, can't ventilate in an emergency situation. As in trauma patient, I may face an emergency department in ICU in a critical situation. So I have to quickly assess and evaluate my patient and not to omit anything important. So let's start with the anatomy of the upper airway. Upper airway composed of nasal, nose, or nasal and oral cavities, pharynx, larynx, trachea, and principal bronchi. I have to know the physiology and the function of upper airway. Nose, the most important function of nose is humidification, warming, and filter the air entering our body. Okay, so I told that nose warming the air enters our body as it enters our body. So how this happened? Our nasal cavity contain many capillaries and blood vessels. They warm blood air entering our body. So be careful when you're doing nasal intubation or you're doing nasopharyngeal airway. You have to lubricate it well, not to injure any of the blood vessel, and you will have a horrible bleeding. Pharynx is a connection between the oral and nasal cavity. It is a muscular tube connecting nose and oral cavity with the trachea and esophagus. Its function is to humidify and warm the air entering our body. There is, as we mentioned, other part of our airway is a larynx, trachea, and principal bronchi. Let's know the anatomy of the adult larynx. I will not talk about infant larynx, and because I talk a lot in the videos of infant anesthesia in anatomy, and I make a comparison between adult and infant larynx. You can go to the video and watch it. Now I will talk about adult larynx. Larynx marks where the upper airway ends and the lower airway begins. Larynx is a complex structure formed by many independent cartilaginous structures. It is cylindrical in shape. In adult, located at the level of C3 to C6, and usually C5. Extend from epiglottis to the lower level of cricoid cartilage. Is formed of 3 unpaired cartilage and 3 paired cartilage. The 3 unpaired cartilage are epiglottis, thyroid cartilage, and cricoid cartilage, as in the picture. The 3 paired cartilage are arytenoid, corniculate, and cuneiform cartilage. Thyroid cartilage is formed of V-shape anteriorly. It's Adam apples. Cricoid cartilage forms the lowest portion of the larynx. Here we will see the larynx in a laryngoscopic view. If only they look that good. Oh my God! When we direct laryngoscopic attempt and when we intubate our patient, we see this view. Larynx, when we do direct laryngoscopy, we will see the larynx like this. Glottis is the area between the 2 vocal cords. It is the narrowest portion of adult airway. Vocal cord is formed by the thyroarytenoid ligaments. It attached anterior to angles in the thyroid cartilage anteriorly and arytenoid posteriorly. In adult, it lies at level of C6. In infant, it lies at level C3 to 4 level. During swallowing, it moves up to C1 and C2 in infant, not in adult. Epiglottis. Epiglottis. I love epiglottis. All of us should love epiglottis because it's an important anatomical landmark for anesthesiologists. Because once we saw, when we're doing direct laryngoscopy, once we saw epiglottis, so we feel happy that it's easy to intubate. I can intubate. Epiglottis is a movable leaflet-like structure. It covers the airway during swallowing, prevent food and fluid to enter the larynx and choking and aspiration to occur. Cricothyroid is very important to know. It lies between, it is a membrane lies, cricothyroid membrane is a membrane lies between thyroid cartilage and cricoid cartilage. This is the landmark for surgical airway. Innervation of larynx is very important. Larynx is innervated by the vagus nerve. That's why when we're doing laryngeal manipulation, we have to be gentle, because any stimulation in the larynx or any rough manipulation or vigorous manipulation on the larynx, we stimulate the vagus nerve. So stimulation of vagus nerve leads to parasympathetic activity and bradycardia, maybe cardiac arrest. That's why we're giving atropine as a pre-medication before intubating our patient to guard against cardiac arrest or bradycardia due to stimulation of vagus nerve. Let's start with first recurrent laryngeal nerve. It's very important for us also. It gives a motor branch for all intrinsic muscle of larynx except cricothyroid muscle. It gives sensory branch to area below vocal cord. Okay, when this nerve, when the recurrent laryngeal nerve cut during thyroidectomy, when surgeon or the surgeon cut recurrent laryngeal nerve on both sides, and this is difficult to happen, to occur, God save us, all muscle of it supply motor branch to all intrinsic muscle except cricothyroid muscle. So the only escaped muscle or spare muscle is cricothyroid muscle. You will find, if it's cut on both sides, you will find your vocal cord adducted and severe laryngospasm will occur. Okay, so before removing endotracheal tube after thyroidectomy operation, before extubation, you have to be sure that recurrent laryngeal nerve is intact and vocal cord is mobile. Okay. Other innervation of the larynx is the superior laryngeal nerve, and it's also branch of the vagus nerve. External branch give a motor to cricothyroid muscle, and internal branch give sensory innervation to area above vocal cord. Okay, let's stop here and continue in another lecture how to evaluate and predict difficult airway and preparation for difficult airway and algorithm for difficult airway. والسلام عليكم ورحمة الله وبركاته. أتمنى أكون فدتكم الحمد لله، وأكون قدرت أفيدكم بحاجة، وأتمنى دعوة حلوة ليا ولأسرتي ولأمي بجنات الفردوس الأعلى بدون حساب ولا سابقة عذاب، والوالدي الله يرحمه ويحسن إليه. وأتمنى أكون فدتكم، ونكمل المرة الجاية، وإن شاء الله إن شاء الله مش هتأخر عليكم بإذن الله. والسلام عليكم ورحمة الله وبركاته.